Hello everyone and welcome to the Frontline to Finish Line podcast, where we bring you the fascinating multidisciplinary insights from the world of sports and exercise medicine. Learn from industry-leading sports medicine consultants, physiotherapists and medical experts and hear the perspectives of their patients as you join us for an interesting series across 2024. My name's Dr. Ralph Mitchell. I'm a GP with a special interest in sports and exercise medicine.
And I'm Chris Speer. I'm a physiotherapist with an interest in musculoskeletal care, and I'm also a Pilates instructor. We're so pleased you've found us and hope you enjoy the listen.
Good evening. Welcome to another episode of Frontline to Finish Line, the Faculty of Sports and Exercise Medicine podcast. I'm Dr. Ralph Mitchell. With me tonight is my co-host Claire.
Hello.
And today we're absolutely delighted to bring you a fantastic guest who has really got a huge passion for one of the key strands, I suppose, of sport and exercise medicine, and that is working specifically in exercise medicine and bringing physical activity to the National Health Service and across secondary care. I'm delighted to introduce tonight Dr. Chris Speers, who is a consultant in sports and exercise medicine working at the Nuffield Orthopaedic Centre in Oxford with the Oxsport and complex musculoskeletal teams. Chris has got a huge background in sport, working as a doctor at Aston Villa, both the academy and the first team. And he's been the chief medical officer for British universities and colleges sport and has a wealth of elite sport experience at major European and world competitions, including the Cricket World Cup in England in 2019. Chris, most importantly as well, is a fellow man from Northern Ireland, which is brilliant to hear. We're getting our contingent of Northern Ireland people through here, which is brilliant to have and to see. Chris, you're very, very welcome this evening.
Hi, guys. Thank you for having me. It's a pleasure.
So, Chris, first question, I suppose, a good place to start with. What's brought you to where you are today? How have you got into the field that you're in now?
That's a good question. Well, you sometimes stumble across these things, don't you? But I mean, I've always been interested and driven by the physical activity side of sports and exercise medicine. And when I was going through my training, the opportunity arose to get involved with movement medicine in its early phases, and I suppose that sort of sparked the interest, and quite enjoyed the sort of team working element to deliver these projects and actually produce something tangible in the movement medicine website and each module. So I think I'm on my fourth movement medicine module now that I've been involved with in some capacity, and that sort of sparked the interest there. And then, I mean, keeping it a bit about physical activity, then what led on from the movement medicine whenever I was trying to find a job as a consultant was this opportunity to work with the team in Oxford on the Active Hospitals project, which was a really exciting project at the time, pilot project funded by Public Health England, as it was back then in 2018, 2019, to sort of deliver physical activity interventions in secondary care and see what impact that could have on patient care. And that sort of got me interested in going, and through that role, I was able to lead the Active Hospital team and be very involved with movement medicine for quite a few years. And then off the back of that, got involved in the faculty council, and then was challenged to create a new exam in exercise medicine. And here we are today. So one thing leads to the next, doesn't it?
I can see you going through the the pathway up to the very top. I'll be a government minister for physical activity or something like that. It's actually probably quite needed, isn't it? It's actually not a bad shout.
Yeah, actually, yeah. Maybe we need to get some people in there, don't we?
The obvious question from me, and as a physio, I know this, but I guess anybody listening to this who might not be familiar, can you tell us what is meant by exercise medicine? What is that strand of medicine all about in your perspective?
Yeah. So exercise medicine, I mean, is the term exercise doesn't necessarily isn't the most important word in it. So basically, it's all about physical activity. So it's about moving, and that can take any form or any shape, depending on who you are. So I think the important thing is it's about moving. It's about moving more, and what we know from sort of the evidence out there and the sort of trials and data that have been looked at is that if you move more and you're more active, it reduces your risk of disease. And that's the ultimate sort of message really around it. So what exercise medicine tries to do is a few different strands. So we can use exercise to try and prevent disease, and we can do that by trying to get the message out there that this is a good thing to do. We can influence government policy. We can influence local council sort of policies. We can think about travel. We can think about design and architecture and how you build things. So there's lots of ways that we can think about exercise medicine and apply it to real life to try and help people be more active. And in doing so, the ultimate goal is to reduce your risk of death, improve your quality of life, improve your quality of disease-free life. And we know that being physically active does all those things. I mean, the classic thing that people say is that, if we could bottle physical activity or put it in a pill, it would be like a wonder drug that everyone would want to take. And actually, but we can't do that, can we? But we need to get the message out there that actually this is something that you can do. You can usually do it for free. You can usually do it really easily. You just got to sometimes create time, and there are barriers to overcome. And that's part of the sort of public health element of this bit, which is challenging but really interesting that some of these tools like movement medicine try to tackle.
It's interesting. I mean, it's great to hear you talking about moving more, but in some ways, if you take a step back and zoom out a bit, that every public health message on physical activity doesn't appear to be working or has failed because our physical activity levels are going through the floor.
Yeah.
As a nation, as a population level, we're actually becoming less active now, despite these messages. We've been banging this out for decades, if not centuries, to say exercise is good. Why aren't we doing it?
That's a really interesting question. So, I mean, to me, I think there's probably more subtlety in it than simply everybody isn't exercising. We know across the population there's a lot of discrepancy, and there are certain populations who are probably actually doing more exercise than before, and maybe eating healthier and doing lots of exercise, lots of good things. But there's many people who are struggling, and they're struggling for a lot of reasons, and it's a complex system to unpick. But that sort of take a step back and look at the broad picture. I mean, the most obvious reason why we're moving less, doing less physical activity is that the built world is different. We don't have to. The way we socially interact and the way we go about work and jobs and sit and talk to each other in our living rooms without getting up and physically having to move to go anywhere to do it, technology and the way things are, that is going to be a massive contributor to this. And I think, we joked a bit about, like the Department of Physical Activity or what have you, but actually, that high level, maybe not necessarily government, but government driven or led approach is going to be really important. And I think that's what the faculty are trying to do through their sort of leadership role, is trying to drive that agenda and make people realize how important it is. Because the more we talk about it, the more we bang that drum, the more people listen. I always find it quite interesting, the sort of built world bit of it. And whenever I did in my sports and exercise medicine training, I did 6 months with the Warwickshire County Council. And the project I did whilst I was there was like an active travel policy for the local area. So the town I lived in, the two towns I live in, Leamington and Warwick, and we'd got all this data about how people travel, and like 60% of people get in their car and travel for less than 2 miles, and that's like 60% of the journeys are less than 2 miles. So people are just really getting in their car to drive around the corner, and then they're driving back. So, I mean, how do you tackle that? That's so difficult, isn't it? I mean, we made this sort of active travel policy to try and improve infrastructure and give people the ability to do that and move more and walk more. Um, but it's difficult and it's complex, isn't it? So I don't have all the answers to that question, Ralph.
Do you think it's the messaging itself has been poorly delivered? I mean, obviously there is natural barriers there, but the message of being
Yeah.
like, oh, exercise 30 minutes 5 times a week is good for you, but nobody knows the consequences if you don't exercise. You know, the diabetes risk, the dementias, the cancers, all the metabolic disease down the line. You know, is that maybe
Yeah.
what?
So when we need to go down more of a smoking fear factor thing.
Yeah,
I
yeah,
think there's a push and a pull, isn't there, for some of these motivations? I mean, the approach that moving medicine and we tried to take with active hospitals, and Natasha Jones and Hamish were sort of instrumental in helping us sort of formulate that and put it into practice as a sort of part of the team, was to look at sort of evidence-based behavior change work. So looking to see what things work, and that was specific to healthcare, to try and help people change their behavior. And so, for example, like the active conversations course that the faculty run is all about how to have those sort of physical activity conversations, but in a behavior change, based in behavior change sort of theory, and trying to help people come up with their own empowering reasons to change their behavior, and make it very personalized and personalized care and conversational rather than you must do this and you mustn't do that. So I think, I would try to practice that in my clinical practice, and I'm sure a lot of people do. And actually, when you break down how you help people change their behavior with an injury or what have you, or whatever it might be, we often find that, we're actually probably doing a lot of those behaviors, but it's quite nuanced. It's not like that's a difficult thing to deliver as a public health message. So in an individual conversation, I think, that can be really powerful. And I suppose that's probably what, as clinicians, we'd be more comfortable with, rather than that sort of public health messaging. But clearly, the public health messaging hasn't got through. Otherwise things would be a bit different. Yeah, and the other thing I suppose worth mentioning is is teachable moments. So that's part of the reason why teachable moments are behavior change opportunities. So that was one of the reasons why the active hospitals pilot was sort of put in place, was to try and see if when people interact with healthcare is often a really good opportunity to help them to change their behavior because something's happened. How you sustain that in the long term is the most challenging bit of it, because so whatever the thing is, whatever the illness is, people are often at that point like, oh my gosh, I need to do something because my behavior up to now has led to this. So you've got this opportunity there. And if you can capture that in the secondary care environment, that's really important. How do you carry that into the rest of their lives and help them to sustain that is the next bit. And we did some really nice projects doing follow-up phone calls and reminders. And there's a lovely service in Oxford called Here for Health that do phone call based motivational interview type interventions for all sorts of healthcare behaviors. But physical activity is a big one they do. And you can show that works in trying to help people change, but it's got to be driven from within. The people have to want to do it, and it's got to have their own motivations. And I think that's the skill of the clinician in that, is trying to pick those out for the patient. Yeah, well, that was the approach we tried anyway. It's very individual.
Yeah, it's kind of that one size doesn't fit all, but we're always trying to fit the population into those brackets. It's a challenge, isn't it? I think I saw something recently, came across kind of, we talk about health changes in terms of being more active, about how we can improve the present so we can be stronger, we can be fitter right now, but actually we don't think about 5 years, 10 years. You need to be starting preparing in your 40s for your last decade of life almost. And I thought that was quite an interesting way of looking at it. We don't know what our last decade will be, but we're doing exercise now for our last decade, not for the next decade, if that makes sense.
And there's a really interesting, very recent topical paper. There was a paper looking at lots of different like a sort of meta-analysis type assessment of cohort studies, and that showed that if your physical activity and your mortality risk are related, irrelevant of the age. So it doesn't matter when you start, so it's going to make an impact. And we know as well from the evidence that the people who stand to gain the most often do the least. So even if you do only if we're quantifying it by the minutes, like the chief medical officer does in their guidance, if you do only 10 and you get up to 20, that increase is a massive reduction in your mortality, in your relative risk reduction. That's a massive relative risk reduction for your mortality, compared to someone that does 60 going up to 70. So those 10 minutes are different depending on your risk. So the people who we come into contact with often are the people that do the least. So we have a big opportunity, I think, as healthcare professionals to make an impact there, albeit on a one-to-one basis. But I think that's probably the bit that I think for me is most important, that I don't think healthcare professionals think about it often enough, and I don't think they realize quite the power that they have to try and help someone think about this and change their behavior. We know that patients trust doctors, nurses, physios, etc., and they trust what they say. So speaking about asking people how much exercise and physical activity they do is really important. It makes it. I always ask people about smoking, but lots of people don't ask about physical activity. I think we've got to do that more.
How do you classify physical activity, Chris? Because that's something that I've heard debated as what actually is in terms of physical activity. People say, well, I walk my tiny little chihuahua around the block for 11 minutes in the morning. I walk the dog everywhere, and that can be different things if you've got a Great Dane or a chihuahua. So in my head, I would think that physical activity is anything other than walking, because that's what we sort of, as Homo sapiens, have been sort of geared up to do our entire lives. And even 50 years ago, we walked to the factory, walked home from the factory, or things like that. But what are you seeing as, maybe it doesn't have to be the sort of the official definition, but what do you see as the definition of actual physical activity rather than what people are doing?
Yeah, so I think for me, physical activity is anything that increases your sort of heart rate, your respiratory rate. That is different for different people. I completely take your point about walking, or sort of very low. It depends on the pace of the walking as well. So everything is different. You can power walk and walk really fast, or you can dander, and they're very different in your energy expenditure. This is why everything's slightly different, isn't it, for different people? So it is an individualized thing, and it's personalized to the individual in front of you. More is better. So to some extent, if we're talking about someone that does literally nothing and very, very little, and like the classic thing is that they're going to work, and one thing I don't count as physical activity or exercise is work, right? Yeah. With the exception, some manual jobs are obviously clearly really, really heavy work, but that's a classic one that people tell me in clinic, or what you do for exercise. Oh, I'm really busy and working on my feet all day. So I often then would challenge that and say, well, what else do you do to push beyond that? Because it's, that's something that you can maybe try and motivate someone to do a bit more, or help them just reframe, what they do in a day. Like, do you do any exercise for yourself or with friends or what have you? It's actually enjoyable rather than work. It's not like and try and reframe that actually maybe we could do something for ourselves and get something back out of this, and it would also be healthy. So yeah, I think walking is okay in certain circumstances, but it depends how much you're doing, how fast, and how hard you're pushing it. I mean, you can get very technical about this, but it's not very helpful for people. You start talking about nets and stuff, and you just lose people, don't you? It's not going to help anyone. So I'll probably take a very pragmatic approach to it.
That kind of feeds into the reason. I mean, we know we want to get people active because we want the cardiovascular benefits and the physical benefits, but actually that mental health benefit. And for me, if somebody says to me, going out for a half-hour walk every other day with my best friend while we chat, and I'm happy with that. You know, that for them is that mental health. It's being active. It's not sat on the sofa having a coffee and chatting. So I'm gonna respectfully disagree with you there, Ralph. Because I think I would be very happy if, as long as they're getting the heart rate up. I get it, a little kind of potter around, but you know,
yeah. It's got to be something that people want to do though, and it's got to be interesting for them, and it's got to be engaging for them. There's no point in telling people that they got to do more exercise, you got to go and run on a treadmill, because you know loads of people aren't going to like it. Now some people will, but lots of people won't. So you know, like you know, I usually just say to people like, what stuff do you like to do? What do you want to do? What would make you happy? Another one I always ask people is like, what do you do for yourself? Do you get any time to yourself? How do you get that time? You know, but lots of people love gardening. Gardening is a classic one, isn't it? And you know, that can be that is a form of physical activity, isn't it? You know, you're walking around, you're probably, depends how big your garden is though, but and you still, but they've got to like doing it, otherwise they're just not going to do it. They're not going to integrate it into their life. They're not going to make it important. It's not important enough to them. You know, some people love classes, some people hate classes. So many people are polarized about swimming, and swimming is a really challenging one because I think it's a great form of exercise, but it's really expensive.
Yeah.
You know, so many people can't get to a swimming pool, never mind afford to pay for it every 3 times a week or something. So I think you got to be pragmatic, and and that's where this sort of active conversations, motivational interviewing approach is really helpful, because it's very much about trying to get that information out of the patient and get them to come up with the solutions for themselves.
I suppose that touches into the dose response there. What dose is actually needed? Like is it you're saying there about getting 10 minutes to do something, but is that enough to get those big reduction in mortality and morbidity?
Yeah, so I mean, so if when we look at the sort of curve of relative risk reduction, and you plot along the x-axis your number of minutes of moderate intensity physical activity, and you're trying to get people over 30 as a target, because that gives you these massive improvements and benefits. If someone's sitting in an arbitrary 10 and you can get them close to or at 30, the risk reduction for them is significantly bigger than someone that goes from 60 to 70 or 60 to 80. So, the people that stand to gain the most are the ones that do the least. So to me, it doesn't matter. It's about the trend and the progression. And I suppose one other thing is you got they've got to feel good about it and then want to do it again, don't they? So a classic example of that is like, spin class. You go to one spin class, you spend 3 days not being able to walk, and then you go back again.
Yeah.
I always say to people, don't go to a spin class, right? Go and do the static bike and do your own little program and build yourself up.
Yeah.
Because you
Get
don't want to
beasted.
come back.
What's the evidence, Chris, at the moment on wearables at the moment for help for driving physical activity? Is there much evidence out there that it promotes it, that it maintains it? Is a good thing, is a bad thing?
So I'm not sure exactly on the evidence, if I'm honest. I'm not up to date on where we're at with it. I've not had a huge amount of experience of using wearables. I think they're a bit of a barrier for some. Where we did it in the active hospital program, they were a bit of a barrier because they had financial cost. You had to then give them to people and then have a way of collecting the data back off them. So I think there's certainly evidence that they can be very motivating for people, and they can be a way of tracking and getting positive feedback. So I think there's definitely something in that. The IT aspect of it, in terms of like that positive reinforcement and feedback, because most of them interact with an app, don't they? So there's quite a lot of sort of research and projects going in looking at sort of motivational interviewing type interactions through an app. And one of the projects that one of the pathways that we did with the Active Hospitals project, which was in maternity, has had a spin-off research project looking at an app, and that's specifically for pregnant ladies with gestational diabetes, who would have access to an app that could monitor sugar levels, HbA1cs, and then give feedback. You would be able to enter in, and it would link in to tell you how much exercise or physical activity you're doing, and there would be this sort of direct feedback and ability to interact with nurse and that sort of thing. So that's ongoing, and Ralph Smith's been leading on with that. So that's a really exciting development. So there's clearly uses there. That's in a very niche specific area, but you can see how that could be put out across all sorts of different things. Yeah.
I think from a personal perspective, as a subject N equals 1, I'm not going to plug any particular names here, but I have health insurance with a certain provider that gives me monetary discounts and gives me, free cost. I'm not going to mention a name, free coffee every week if I do a certain amount of activity. And I know personally, because I'm from Yorkshire and I buy into the stereotype of wanting to save money and being conscious of trying to reduce my premiums next year, that does motivate me to kind of stay active and be active. I always want to hit my maximum points every.
Yeah, it's an important part of the menu of options available to try and help people change their behavior, isn't it?
Yeah. I mean, yes, granted, you have to be able to afford to have health insurance in the first place to have access to that, but it just makes you wonder if there is a place for a pilot scheme that does give some kind of, I don't know, monetary reward. It depends.
There's lots of them that have been trialed, and there's lots of them that give like discounts and vouchers and all sorts of things, based on the step counts and how far you walk and things like that. So I think there's going to be people that works for, definitely.
Yeah.
I think it has to be looked at a national level. I think because we've rightly demonized smoking now, and the way it is, graphic pictures on cigarette packets, you can't have it openly advertised, etc., etc. Yeah, from what I understand now in the Western society, physical inactivity kills more people now than smoking does. So why haven't we demonized the negative effects of lack of physical activity yet? So I think risk and reward, or giving taking has to be looked at, because if we've got a killer now that's killing more people than smoking, then why aren't we doing more about this? So if there was a new drug on the market that was killing that many people every year, then we would have done something by now. But I think it takes back to, in an individual level, obviously we know we need to get our messages across better, and it sort of touches on quite nicely about we as doctors having experience, having the skills ourselves to be able to deliver the message like you've just talked about there. And obviously the faculty now have just released their next round, I believe today, of the Diploma in Exercise Medicine. Would you be able to tell us a bit more about that, Chris? Then you've been involved in it.
Yeah. So the faculty, as in its evolving state, has three diplomas to gain, and if you get a diploma exam, you obviously get diploma membership of the faculty, and you get all three, and you can become a member. And the exercise medicine one's been the one that I've been chairing and leading on, and this was a completely new exam, so it's been quite a challenge over the past few years, to from scratch create an exam and then run it, and we're very proud to have ran the first sitting of the exam early 2024, and it went really successfully and well, and that was great. So the next sitting is now open, and it's due to sit in 18th of February, so early next year. And the exam itself is meant to assess knowledge and the sort of clinical application of exercise medicine in both health and in disease states, so for prevention and for the treatment of illness. It's a very open exam in the sense that it's designed and aimed at a wide range of healthcare professionals who use physical activity and exercise medicine as part of their daily bread and butter, and ideally that's the sort of person that we want to be applying it, or applying for it, or someone that wants to improve their skills and knowledge in this area, and be validated through actually gaining a diploma examination certificate. It's based on sort of NHS practice. And it's quite real, and it's designed to be real world. So it's very much about application of knowledge to real circumstances you might find yourself in. And I think we've been pretty successful at trying to achieve that with the question bank and the question writers. A huge thanks needs to go out, by the way, to the question writers and the standard setters, who are all voluntary and help to make this exam and hopefully keep it going into the future, because there's a huge amount of work, and as you can imagine, we need to write huge numbers of exam questions in order to get a good enough exam for the next round. So it's a constant sort of battle with that. It's really exciting sort of opportunity for people to sort of demonstrate their knowledge and skills, provide evidence that they know what they're talking about, and validate themselves, show that they're competent and understand things. It's based on guidance and on evidence, and it's open for application now.
How would you suggest people best prepare for the exam? Because I think it's not a course, as having done
there is a course that is run by BASM.
Brilliant.
So there is a revision course run by BASM that they run once a year, sort of with enough time before the exam. And although we're obviously me and my team aren't directly involved in that course, we obviously have liaised. They know what the syllabus is. They know what the sort of that they're going to know what the sort of topics and the standard that we're expecting is. So that's helpful if people wanted to do that. We do have a sort of suggested reading list of texts and important documents that we think is worth knowing about. Ranging from sort of, I mean, it is quite broad. So you're ranging from things like exercise physiology through to sort of applied clinical exercise medicine sort of texts. And then the guidelines are quite important around Chief Medical Officer and WHO. So understanding those is really important to the exam. And I think, a lot of people that have applied for this and shown interest in it, they do a lot of this in their daily practice. So I think one of the things I would suggest is as a tip is one of the best ways to prepare for an exam is to think about real life cases, how you applied your knowledge, read around it, think about risk and why, who would be suitable to do what sort of exercise and why. And that sort of thing is what this is trying to look at. It's that sort of decision making and applied knowledge in a clinical circumstance. It's not a true false. What's the name of this muscle?
Thank God for that.
That's brilliant, really helpful. We'll get our lovely James, who edits the podcast, to put up a link to the page with podcast info. So anybody listening, wherever you get your podcast from, have a look at the page and you'll see the link, which will tell you more about what the exam entails and also how to apply for it. So as we said, applications are open now, and the exam is 18th of February. So plenty of time to revise and prepare. And I think the faculty, as a physiotherapist and one of the first Diploma members, have been so welcoming and so helpful as a group. So if you do go ahead and decide to do the diploma, I would thoroughly recommend going to become a member, because it just opens you up to a wonderful network of people. So
brilliant. Well, Chris, I think we've touched on it a fair bit tonight with yourself. It's been great to hear, first and foremost, your passion and your enthusiasm for exercise medicine. And ultimately, when you think about it, those that are involved, whether we're doctors, physios, or whoever, sports and exercise medicine consultants, GPs, whoever, to work in this environment, one of the things we really need to promote these days is physical activity. And in my talking to my NHS patients and Joe Public as well, that they often have this misconstrued idea that SCM consultants are just there for elite football or elite rugby or whatever. But actually, this shows that, if anything, we've got an increasing importance in the future of our nation's health. And I say not just doctors as well, but everybody involved, physiotherapy and MSK conditions as well, to ensure that we as a nation are becoming healthier. And it's brilliant to see how much you're driving that.
Yeah,
Thank you,
agreed.
Huff.
I would add any clinician, you know, anybody that somebody comes into contact with who has some level of medical knowledge or professional clout. You know, I think we've all got that role to play, haven't we? Which is one of the things that moving medicine and active hospitals has really pushed.
This is multidisciplinary. It's not about your title. This is, everybody needs to be singing from the same hymn sheet and saying the right things. And generally, you know, moving more, being physically active is safe. It's going to help you. And it's applicable across, you know, any sort of application, you know, any part of your life. You know, being more active is going to be helpful, whether you're about to have surgery or you're recovering from surgery, or, you know, you've had a diagnosis of cancer, or you've got a diagnosis of type 2 diabetes or whatever. You know, there's strong evidence that supports physical activity being beneficial and improving your recovery and your long-term health prospects. So yeah, it's vital, and it needs to be part of all people's care plans, really.
Really powerful
Fantastic
message. I kind of always want to wrap up there, but there's one thing I just want to pick up that I found fascinating as we were talking, Chris.
Oh yeah.
About the built environment, because
Oh yeah.
I don't think I've ever heard anybody in the medical world talking about that as a factor. And it did make me think, you know, do we need to be pushing as professionals to be talking to architects and civil engineering planners, and how that influence, how can people get themselves in the rooms to influence that? I think that's fascinating.
Yeah, so I think how you get in your room to influence that is the golden question. So I got a bit of insight into this through my time at Warwick County Council, because the transport department sat beside the public health department, so you got to chat over coffee and stuff a bit. And I mean, clearly it's more than just transport. You know, you've got planning, you've got et cetera, and you've got then the sort of local politics of the thing as well. But, you know, there are a lot of things locally that you can influence if you can get in front of the right people. But, you know, the most frustrating examples are often right in front of us as we, you know, as we rightly try to build new houses, and quite often they come with really good sort of inbuilt within the estates walkways and segregated pathways and car-free areas, but the estate doesn't link with the town that it's next to. There's a dual carriageway and you can't get across the road. So it's incredible. You can see it, and it's incredibly frustrating. And I think we need to do better at that. I don't know how we influence that. I think we try, and I think things like the faculty and pushing forward and gaining influence and a louder voice is important in that.
Yep.
I think that's probably the best way that we could influence things like that, and try and help people to think about physical activity when they're plotting the complexities of town planning and that sort of level stuff. But you know, even down to like our local parks and making sure we secure them and give good access to them. You know, that's so vital and so important for people to be active. And you know, it depends where you live. That changes massively how much access you have to that sort of thing. Because walking down a narrow footpath beside a dual carriageway does not make you want to do that regularly.
Yeah.
You know?
True. Yeah, such an interesting insight. Thank you for raising that, because I think yeah, it's certainly not. I think I've considered the effect of bigger scale, but I don't think I recognise the importance of medical professionals pushing that wherever they get the chance as well.
In quite a lot of architectural building design these days, they do sometimes think about it. But again, I'm sure you can think of many examples where you walk in the front door of a brand new building and the first thing you see is the lifts.
Yeah.
And the stairs are out the fire escape.
Yeah, I took
And
away.
they're like concrete with they've breeze blocks and they're not even painted walls.
Yeah.
That's the built environment for you right there, isn't it?
Absolutely. That's such a strong message that people are sending when they're planning that way. Yeah. That's fascinating. Thank you so much. I feel like I've kind of taken away that lovely, powerful ending. So I'm going to ask you again, just to round up your go-home message, the thing you want to leave the listeners with, they can take away a couple of messages from you. What would that be?
Oh gosh, I think we've got as many conversations as possible need to happen between us and our patients about physical activity. We need to try and help people to find the activity that they enjoy and that they want to do, because they're more likely to keep doing it. Try and move more. It doesn't matter where you start from, anything's better than nothing.
Absolutely. Great message to finish on. Chris, thank you so much indeed for your time. Really, really appreciate it.
Cheers.
Thank you so much. It's been great.